Hello guys, welcome to our channel PLAB.RECAPS. Today we'll be discussing a topic under cardiology, which is hypertension. Any topic which has an asterisk placed next to it is just to provide emphasis that this is a topic that you ought to focus on for your clinical exam as well. What part of the topic you need to know for your clinical exam is something we will discuss with you later. Please note that we will not be discussing hypertensive emergencies or management of hypertension in pregnant women or those who are trying to get pregnant, breastfeeding women, or a management of hypertension in chronic kidney disease. These are topics that will be discussed in their respective specialty folders. So let's begin. In the UK, we use NICE guidelines for the diagnosis and management of hypertension. NICE guidelines were last updated in the year 2019. Hypertension has been classified into 3 stages: stage 1, stage 2 and stage 3. The criteria upon which this is based depends on high clinic BP readings, which should make one suspicious of the diagnosis. However, confirmation of the diagnosis is made by conducting ambulatory or home blood pressures. Stage 1 hypertension is diagnosed as having a blood pressure of more than or equal to 135/85 on ambulatory and home blood pressure monitoring, while stage 2 hypertension is defined as having blood pressure of more than or equal to 150/95. Sometimes there is a bit of a confusion in regards to whether both systolic and diastolic blood pressures need to be raised in order to make the diagnosis. What NICE guidelines suggests is that for stage 2 hypertension, an isolated rise in either systolic or diastolic should be enough in order to initiate treatment. So for example, having a blood pressure of more than or equal to 150 systolic or more than or equal to 95 diastolic should be enough for you to make the diagnosis and initiate treatment. Stage 3 hypertension is also called severe hypertension and can be merely diagnosed on clinic BP readings. So a high clinic systolic of more than or equal to 180 or a clinic diastolic of more than or equal to 120 should be sufficient in order to make the diagnosis. I will talk about stage 3 hypertension and its diagnosis in a little bit more detail later on. A little more clarity around the concepts of white coat and masked hypertension will help us better understand how the UK came up with the guidelines of diagnosing hypertension. Now, white coat hypertension is when you overdiagnose someone with hypertension while they are actually normotensive. So, for example, your patient walks into your clinic and they are found to have a high clinic blood pressure reading. So you arrange for an ambulatory or home blood pressure monitoring, and it is found that the readings are normal there. A difference of more than 20 systolic or 10 diastolic helps confirm this. This basically means that for whatever reason, when your patient came into your clinic, something made him or her anxious, which caused a shoot in his or her blood pressures. Now, masked hypertension is when you're unable to diagnose a patient with hypertension because they appear to be normotensive when they come to your clinic. So when you do clinic blood pressure readings, they are normal. However, outside of the clinic on ambulatory or home blood pressure monitoring, their readings are high. In the UK, in the past, there has been a lot of overdiagnosis and sometimes underdiagnosis of hypertension. So in order to avoid this, there has been an introduction of ambulatory or home blood pressure monitoring in order to confirm the diagnosis. Therefore, it is necessary to arrange for an ambulatory or home blood pressure monitoring for the confirmation of the diagnosis, despite clinic BP readings being high. When a patient comes to you, make sure that you measure blood pressure in both arms. If the difference between the two arms is more than 15, just repeat the process and use the arm with the higher reading for future blood pressure measurements. If the clinic BP reading is high, then just repeat the clinic BP reading again during the consultation. If both clinic BP readings are high and you are suspecting a diagnosis of hypertension, then arrange for the patient to have either ambulatory blood pressure monitoring or a home blood pressure monitoring. Now, with ambulatory blood pressure monitoring, generally there are two measurements that are taken every hour between the normal waking hours of the patient, which is generally between 8 a.m. and 10 p.m. So you get 14 readings, which you then take an average of and document your findings. So obviously, as you can see, that there are multiple measurements being taken during a single hour. So sometimes patients cannot tolerate this, and so for them home blood pressure monitoring is suggested, in which you just take two consecutive measurements which are just 1 minute apart. You take it twice in a day, morning and evening, and you average it over 4 days. Ideally it should be done over 7 days, and then you document your findings. So while you are waiting for the results of the ambulatory or home blood pressure monitoring, the NICE guidelines recommend that you assess the patient's cardiovascular risk and also assess for any target organ damage. As discussed previously, in order to make a diagnosis of hypertension, one needs to have the results from ambulatory or home blood pressure monitoring, and while waiting for this, it is necessary that one assesses their patient for a 10-year cardiovascular risk as well as for any target organ damage. Now this is important because this will contribute to the management. So by the time you have your results back from ambulatory or home blood pressure monitoring, you will be able to make a more informed decision regarding the management if you have already assessed for target organ damage and the cardiovascular risk for your patient. So the way to assess cardiovascular risk is using the QRISK-3 calculator. Previously, the calculator being used was QRISK-2. However, now there is an upgraded version, and currently the one that is in use is the QRISK-3 calculator. For anyone you are suspecting to have hypertension, you need to send a few routine bloods and do some workup. This includes workup for target organ damage, so look for any kidney injury, do urea electrolytes, creatinine, calculate the EGFR, and send urine for albumin creatinine ratio, as well as do a urine dipstick for hematuria. Check for any damage to the eye, so a fundus examination is necessary to look for any hypertensive retinopathy. A 12-lead ECG would help in identifying any left ventricular hypertrophy secondary to hypertension. Now, other bloods include doing an HbA1c, and total cholesterol, along with LDL and HDL cholesterol. Now, let us just walk you through a scenario, so it may help you better understand how all this can be put into practice. So imagine your patient walks into your clinic and his clinic reading is 150 by 90. So what is your next step going to be? So ideally, because it's your first clinic BP reading, you'd want to repeat the clinic BP reading within the same consultation. So if both are around the same value of 150 by 90, so they're clearly high, the cutoff is 140 by 90. So you would like to arrange basically a ambulatory or a home blood pressure monitoring for your patient. And whilst you wait for the results of this, you'd like to assess your patient for cardiovascular risk and for any target organ damage. Now imagine that the results that come back are normal, so blood pressures are less than 135 by 85. So basically this patient just needs monitoring, so they can have their blood pressures checked once in every 5 years. However, if you find that the results from the ambulatory or the home blood pressure monitoring were normal, but however they were more on the upper limit of normal, then you can increase the frequency of your blood pressure checks for the patient. Now imagine if the results from the ambulatory or home blood pressure monitoring came back as being abnormal. The next step would really depend on how do we classify the patient depending on his blood pressures. So if we go back to our previous table, so if the blood pressure comes back to be more than or equal to 135 by 85, then they are classified to have stage 1 hypertension. Generally, patients with stage 1 hypertension require just lifestyle modification and need some monitoring. However, this is where your assessment for your cardiovascular risk and target organ damage plays an important role, because if your patient does have a high cardiovascular risk or any target organ damage, then they may require treatment despite having stage 1 hypertension. So anyone less than 80 years of age and have any one of the following, that is target organ damage or established cardiovascular disease, renal disease, diabetes, or a 10-year cardiovascular risk of 10% or more, will require treatment with antihypertensives. Also, someone young who is less than 60 years old with a 10-year cardiovascular risk of less than 10% will also require treatment with antihypertensives. However, if the blood pressure readings from the ambulatory or home blood pressure monitoring come back as having a blood pressure of more than or equal to 150 by 95, then they are classified to have a stage 2 hypertension. Patients with stage 2 hypertension need to be all treated regardless of age. And if they do have stage 2 hypertension but they are relatively quite young, which is less than 40 years, then you need to consider a specialist referral to look for secondary causes of hypertension. In this particular scenario, the blood pressure of the patient, the patient did not have severe hypertension. However, if the clinic blood pressure is above 180 systolic or greater than or equal to 120 diastolic, then this patient has severe hypertension, and so this patient needs assessment whether they are having any signs and symptoms of severe hypertension, whether they need to be seen same day, whether they need to have a same day specialist referral, or they can be worked up for target organ damage and have their blood pressures checked again. So this is something we will discuss later. Management of hypertension includes both lifestyle modification as well as use of antihypertensive agents. Now, this is something that can be tested for in your clinical exam. They could ask you to counsel a patient who has been recently diagnosed with hypertension. Make sure that before you provide any lifestyle modification that you do investigate and inquire about the lifestyle that the patient currently leads. This puts you in a better position to be able to counsel regarding specific things rather than just providing a general advice on lifestyle modification. Do inquire about the patient's dietary habits, alcohol consumption, fitness, and whether they smoke or not, how much caffeine do they drink. Once you have gathered this information, then you are in a better position to provide some counseling. Ask them to reduce their salt intake. Generally in the UK, the consumption is around 12 grams per day, so this needs to be reduced. The target is 6 grams per day, and ideally best would be to bring it down to 3 grams per day. Do let the patient know that reducing salt intake does decrease the blood pressure by around 10 systolic. This motivates the patient, and he or she would realize that this is a necessary step in the management of hypertension. Advice for regular exercise, whether that includes just brisk walking and a healthy diet. A healthy diet could include just simply advising the patient to cook at home. Majority of the patients here do eat outside because of their stressful working hours, so you can always advise about things like preparing food over the weekend and storing it in the fridge and then using that food throughout the week, and similar suggestions. Regarding alcohol and smoking, make sure that do not advise very stubbornly about stopping smoking, because this is not something which is very easily achievable. Generally, patients find it more motivating if they're able to reduce their consumption before they completely stop. So counsel regarding reducing alcohol consumption and smoking as well. They can get help regarding these things from their GP. You can go into more details if you find that if the situation is suitable to be discussing about nicotine patches and things like that. Also investigate about how much caffeine they are drinking, and ask them to reduce caffeine intake as well. Do not offer any calcium, magnesium or potassium supplements to help reduce blood pressures. Inform your patient about to investigate either online or through their GP about the local initiatives that are available. Sometimes this is in the form of groups that are present around locally, or organizations that are there to motivate lifestyle changes in people. When to start treatment is something we have previously discussed. So once you have results from the ambulatory or home blood pressure monitoring and have assessed the patient for a 10-year cardiovascular risk and done workup for target organ damage, we can now classify the patient as having stage 1, stage 2 or stage 3 hypertension. If the patient has stage 1 hypertension and is less than 80 years old with any one of the following, that is target organ damage or established cardiovascular disease or renal disease or diabetes or a 10-year cardiovascular risk of more than or equal to 10%, then this warrants you to consider starting antihypertensive treatment. If the patient is young, for example less than 60 years, and their 10-year cardiovascular risk is less than 10%, it still indicates you to start the patient on some type of antihypertensive medication. This is because the patient is young, when you calculate the cardiovascular risk, it may not necessarily identify or underestimate the risk of developing a cardiovascular event in the next 10 years, which is why NICE recommends that if they are less than 60 years with stage 1 hypertension, you should consider starting them on treatment. If the patient has stage 2 hypertension, then they need to be offered drug treatment irrespective of their age. If the patient is less than 40 years, you need to make a specialist referral for to consider secondary causes of hypertension such as renal disease or renal artery stenosis, pheochromocytoma, thyroid dysfunction, acromegaly or Cushing syndrome. If the patient has severe hypertension or stage 3 hypertension, then you need to look for signs and symptoms which indicate same-day referral. So ask for things like headache, nausea, vomiting, blurring of vision, any chest pain, orthopnea, change in the color of urine, generalized weakness, lethargy. All these warrant referral for same-day specialist, to be seen by a specialist on the same day. If these are not present, then you can carry out investigations for target organ damage. If there is any target organ damage, then you do not have to wait for any ambulatory or home blood pressure monitoring. You can directly start the patient on antihypertensive medications. However, if there is no target organ damage, then just call the patient back to your clinic in 7 days and repeat the blood pressures. Thank you guys for your attention. We hope that this topic presentation was helpful. If you did find it beneficial, kindly leave your comments below and also leave us some suggestions on how we can improve. See you soon in our next presentation. Thank you once again, and together we can do this.